Hi, I'm Dr. Scott Worden, the TOS guy. Today, we'd like to present our first TOS case study. The subject of our first case study is a young healthy woman with a known right cervical rib on radiographs who has signs and symptoms of thoracic outlet syndrome. MRI images of the cervical spine demonstrate normal neural foramina on the right side and on the left side, no central canal stenosis. Initial images of the brachial plexus demonstrate focal thickening and abnormal signal intensity in the divisions and chords of the right brachial plexus as they pass over the right first rib. Grayscale sagittal images through the same area demonstrate the thickened right brachial plexus with poor definition of internal structure, as well as a cervical rib, which is located inferior to the brachial plexus and inferior to the right subclavian artery. With the patient's arms elevated, sagittal images through the right thoracic outlet demonstrate the right clavicle approaching quite close to the right first rib, causing marked narrowing of the space between them, the costoclavicular interval. We can see how the brachial plexus is severely compressed with no residual perineural fat, and it's quite hard to find the lumen of the right subclavian artery due to compression. MR angiogram performed at the same time demonstrates an abrupt termination of the right subclavian artery as it approaches the first rib. Close-up images demonstrate trace distal reconstitution of the right axillary artery, but clearly there's severe compromise of arterial blood flow to the right upper extremity. You may have noticed on the initial images of the brachial plexus that the left brachial plexus is also thickened with abnormal signal intensity at the level of the first rib. Grayscale images confirm this, with focal thickening and poor definition of the internal structure of the left brachial plexus. And while initial MR angiogram demonstrates the abrupt cutoff of the right subclavian artery, there is also a severe extrinsic compression of the left subclavian artery, with a little antegrade flow in the left axillary artery, representing severe compromise of arterial blood flow to the left upper extremity. The reason for these findings is not a cervical rib, but in fact, with the patient's arms elevated, we can see how the left clavicle approaches quite close to the left first rib, causing severe narrowing of the left costoclavicular interval. There's compression of the left brachial plexus with severe effacement of perineural fat, and there's a narrowed lumen of the left subclavian artery, which we already know from the MR angiogram images. Important findings on the right side include the cervical rib, which contributes to severe compression of the right brachial plexus with focal thickening, severe extrinsic compression of the right subclavian artery with occlusion, and no evidence for nerve impingement in the normal neural foramina. On the left side, while there is no cervical rib, we'd still see severe compression and moderate thickening of the brachial plexus, severe extrinsic compression of the left subclavian artery, and no evidence for nerve impingement in the normal neural foramina. It may help to recall that about 0.5% or less of humans have a cervical rib, almost always incidentally discovered on radiographs, without symptoms. In our experience and in the medical literature, most TOS patients do not have cervical ribs. The association between a cervical rib and thoracic outlet syndrome is a historical relic. TOS cases have been reported in the medical literature as far back as 1818. In 1895, Röntgen produced the first medical radiograph, which enabled physicians to see cervical ribs in living patients. In the early 20th century, several papers were published demonstrating a neurovascular syndrome in patients with cervical ribs, and thus was born the age of the cervical rib syndrome. But shortly thereafter, several physicians also published papers showing patients with the same neurovascular syndrome with no cervical rib. And thus we got the cervical rib syndrome without a cervical rib syndrome. In 1920, A.A. Law published the first cadaver study demonstrating a number of soft tissue anatomic variations and anomalies in the thoracic outlet. These findings have been duplicated on a number of studies in the decades since. In 1939, Eden documented the mechanism where arm motion caused the clavicle to approach the first rib, narrowing the costoclavicular interval and potentially causing neurovascular compression. In our practice, we do not perform or recommend radiographs. Even in the presence of a cervical rib, we feel there is very little useful information. A cervical rib may be present on radiographs, but radiographs cannot demonstrate soft tissue anomalies, they cannot demonstrate compression of the neurovascular structures, and they cannot demonstrate the mechanisms that cause compression. Additionally, radiographs are unable to document narrowing of the costoclavicular interval. On the other hand, a good MRI examination, such as our NeoVista examination, can document cervical ribs, but it can also demonstrate the important neurovascular structures, whether they are compressed or normal, what structures are compressing them, and narrowing of the costoclavicular interval. At Vanguard Specialty Imaging, we always say, don't guess with TOS. Thank you for joining us in this video, and we hope you'll visit our next one.